Am I audible? Hello?
Yes, you're audible.
Yeah.
You are audible.
So my screen has been set.
Yes, it's visible.
Yeah, okay, thank you. First of all, namaste to each and everyone on the board. I'm Dr. Alpesh Fefar. I'm ENT consultant at Radhe ENT Hospital, Gujarat, India, and I'm ex-associate professor at Medical College, India. Today's my presentation is bilateral single sitting tympanoplasty. Should we do it? As we know, tympanoplasty is a surgical procedure to eradicate disease from middle ear to reconstruct hearing chain mechanism with or without tympanic membrane grafting. Perhaps tympanoplasty is the most common surgery performed on the ear worldwide, but mostly on one side. In routine practice, we see many patients having bilateral CSOM. The aims of my today's study is why we should do bilateral tympanoplasties. Actually, it is usefulness, the techniques we perform, what are the limitations and solutions, and success rate. Why? The article dates back in 2009 that like ear, eye is also a special sense and sensitive organ. So bilateral sequential cataracts were done at the time, and after that, we can see that bilateral single sitting total knee replacement is also done. Apart from that, the article dates back in 2009 that is about bilateral simultaneous cochlear implantation. So if cochlear implant can be done bilaterally, then why not tympanoplasty? We are master of tympanoplasty. We are doing enough of tympanoplasties in daily routine. So that is why we should go for bilateral tympanoplasty. How it will be helpful? Developing countries have limited resources. So performing tympanoplasty on both sides in single sitting will result in better utilization of resources. There will be a reduction in daily adjusted life years, and it will reduce burden on the healthcare system. And how it will be useful? There will be reduction in total time of surgery because there will be reduced time for scrubbing. You have to scrub for one time only. OT preparation time for taking graft material is reduced. Anesthesia point of view, if it is done under general anesthesia, then time of second intubation and extubation is saved. There is reduction in overall cost. Drugs can be utilized in better way. Manpower related cost is reduced. Reduction in the cost for autoclave, that will save electricity. And there will be reduction in the absence from school and workplace. What are the aims and objectives of my study? To study outcome of single sitting bilateral tympanoplasties and to study effectiveness of performing bilateral single sitting tympanoplasties. Materials and methods. I have taken permission from Institutional Ethics Committee. This is prospective study for 2 years. We have taken 100 cases that amounts to 200 years and patients with 15 to 65 years of age of both sexes were taken. Exclusion criteria. The patients who are having discharging ear, suspected ossicular involvement, patients age below 15 years or who are above 65 years of age, patient having airborne gap of more than 55 decibel, or patient having any active septic foci, and in revision cases, we have not done bilateral tympanoplasty. Patient selection, how we have selected the patient. When we see the patient of bilateral CSOM in our OPD who are having mild to moderate conductive loss and who are having dry ear for at least 1 month, we offer them bilateral tympanoplasty. We explain them about the advantage and disadvantage of performing bilateral tympanoplasty. So out of them, 120 patients consented for bilateral tympanoplasties. But in 10 patients in the first year, we have to do ossiculoplasty. So second year surgery was not done as per our exclusion criteria. And 10% lost follow-up. So finally, we have taken 100 patients and that we are presenting it. How tympanoplasty was performed? So first of all, determination of side is important. We have taken the side in the side where Weber test is lateralized. And in case of equivocal Weber, the side of patient's preference is done. Approach. Either we have done bilateral transcanal approach or one side post-oral and another side transcanal approach. Graft material. In case of bilateral transcanal tympanoplasty, we have taken tragal cartilage with perichondrium. And in case of post-oral tympanoplasty, we have taken temporalis fascia. Important thing is that we have harvested graft from only one side, and we are doing exclusively underlay tympanoplasty. We have done follow-up on 1 week, 3 weeks, 6 weeks, and 24 weeks. And considering graft status at 6 weeks is considered for result. We are also doing Puritan audiogram, and we are comparing with the pre-op audiogram. We have collected the data, it has been grouped and analyzed. This is the simple pro forma of patient collection information. This is the analysis of data. Majority of our patients are in middle age group. Almost 28-27% in 26 to 35 and 36 to 45 years of age. Average time for surgery. The time taken for first surgery is 51 minutes and for second surgery is 38 minutes. Time for second surgery is reduced because the time for taking graft, doing hemostasis and all that procedure time has been reduced. Graft take-up rate. In case of temporalis fascia, the graft take-up rate is 96% and compared to tragal cartilage, which is 93%. But overall success and overall graft take-up rate is 94%. So no, there is not a single case where there is a bilateral failure. The patient have failure on only one side. So all our success rate for first year graft is 96% and for second year graft is 92%. That totally amounts to 94%. We have applied Fisher's exact test and that value is 0.4942, so that is not significant. Audiological comparison. For temporalis fascia, pre-op average threshold is 39 decibel and post-op average threshold is 14 decibel. So there is average gain of 25 decibel. While in case of tragal cartilage, average pre-op threshold was 42 decibel and post-op average threshold is 18 decibel. So average gain is 24 decibel. So there is no much difference. Airborne gap closure. Airborne gap closure up to 10 decibel has been achieved in 152 patients out of 200 years. So that is 76%. And less than 20 decibel has been achieved in 176 years. So that is 88% of cases. In other patients, we are able to achieve more than 20 decibel gap. So conclusion, graft take-up rate is 96% with temporalis fascia and 93% with tragal cartilage. Overall graft take-up rate is 94%. So the success rate in first year is 96% and second year is 92%. So the second year success rate 92% is almost comparable with any unilateral tympanoplasties. And average gain of hearing threshold is 24.33 decibel, which is comparable with other studies. Not a single patient develops sensory hearing loss. That is the theoretical possibility. We all are masters of unilateral tympanoplasties, so we must do bilateral tympanoplasties. Bilateral simultaneous tympanoplasties can be performed safely and effectively as a single stage operation with high success rate without any complications. This is not the end, this is just the beginning. Multicentric double-blind studies are required. Thank you. Is anybody having any question?